neonatologist here. I'm really excited. I'm going to be telling you about our speaker, Dr. Jonathan Klein, in just a moment. But I just wanted to remind everyone that if we could please hold our questions until the end of the presentation. And the best way to address each question is if you could please type the question in the chat box, and I will also be moderating the question and answer here at the end of the lecture. First of all, for Dr. Jonathan Klein, I just wanted to express this is a real privilege to have you to do this for us. Thank you so very much. Dr. Klein completed his undergraduate education at Johns Hopkins University. He went to medical school at the Medical College of Virginia, Virginia Commonwealth University. He did his pediatric residency at the University of Texas Southwestern Medical Center, Children's Medical Center in Dallas, and his neonatology fellowship was done at New England Medical Center, Boston Floating Hospital, Tufts University. Dr. Klein has been a professor at the University of Iowa since 1990. He has served as the NICU medical director there from 2005 to 2023. And he is currently the Professor Emeritus of Pediatrics. Dr. Klein has worked with multiple modes of high-frequency ventilation since 1987. He has extensive experience in multiple publications on the use of first-intention high-frequency ventilation for extremely preterm infants born at the limits of viability. So it is without further ado, it is such a pleasure to introduce you, Dr. Jonathan Klein. Thank you so much.
Okay. Thank you for giving me this opportunity to talk with everyone about first intention high frequency. So, of course, the first thing is let me make sure I can actually share the talk. So that's always a and. Post. Okay, can someone just confirm that you guys can hear me and see the slides?
Yes, we can.
Okay, and then I'll probably, we'll all keep trying to mute ourselves, so I'll let you know if I hear issues. I'll let you know. So this talk will take around 50-ish minutes, and then I'll stay around, answer questions as long as you wish. And there'll be things that we might be able to go into a lot more depth, because I know we're also going to do more of a workshop where, in that case, we'll actually want more interactive interruptions during the talk. So we'll set that up a little bit differently. But this, I really wanted to create this more as a formal background talk and then do the questions at the end. So as I've been modifying this talk over many decades, we're going to focus on the concept of neuroprotective respiratory strategies for the care of infants born at 22 to 123 weeks gestation, first intention high frequency jet ventilation is our primary mode. And as you can see here, there is a set of twins now from 7 years ago, 22 and 1 7-week twins born early because of twin-twin transfusion syndrome. And this is the girls at age 6. And then recently we had a baby who is 21 and 0/7, so he's the most premature baby on the planet now. And he was 285 grams, and as you can see, he was first intention jet ventilation there. Nothing to disclose, no contact in terms of financial relationship with any corporation, and permission from all the families. And what I'm showing you here would be the smallest baby ever on the jet. She was 240 grams, 23 5/7 weeks, and you can see her there, and you can see her here. Her first birthday, but actually, she's 4.5 months premature, so she's really only 6 and 5 months there. So the objectives are fourfold. One, we want to understand the impact of antenatal steroids and the importance of fetal lung development on ventilatory management strategies. The strategies done at the canalicular stage are different than the strategies done at the saccular stage. So big difference between 22 and 26 weekers. We want to identify unique ventilatory strategies for infants born before 24 weeks gestation. using low tidal volume ventilation to reduce shear force injury, and in this population, air trapping. And this is optimizing first intention jet for this purpose. We're going to also talk about differences in supportive strategies used for respiratory management when caring for infants born before 24 weeks. And I want people to concentrate on balancing neuroprotection with lung protection. And we'll look at pulmonary neurodevelopmental outcomes that we've published when using first intention high frequency ventilation with the jet. So at baseline, we've been doing this for a very long time. So if we look at survival and outcomes with the first intention high frequency jet for premature infants born at 22 to 24 weeks gestation, this is covered over 18 cumulative years right here. At 22 weeks, survival of 22 weeks is 66% out of 77 babies admitted, 78% out of 23 weeks out of 100 babies admitted, and 86% at 24 weeks out of 132 babies admitted. And I'm kind of showing this over a long period of time because there's always small numbers when you're dealing with these very low gestations. We certainly have had periods of time that our survival is equivalent to Japanese. I'll let someone mute themselves. Is equivalent to Japanese data here from the period of 2021 to 2024. 22-week survival was 79%, 15 out of 19. Outcomes that we had published back in 2020 at 22 to 23 weeks. I'll let you guys mute yourself. Why don't you go ahead and mute there? At 22 to 23 weeks, severe neurodevelopmental impairment was just 11%, and at 24 to 25 weeks, severe neurodevelopmental impairment was only 4%. And you can see no or mild was 62% at 22 to 23 and 77% at 24 to 25. And we know based on work that when you repeat these studies from at age 2 to age 10, almost 53% of these babies even shift further into no or mild. So our primary goal is survival with intact neurodevelopmental outcome. Neuroprotection must outweigh lung protection. Protecting the brain from injury is more important than a total focus only on minimizing lung damage. And I will tell you, for the past 50 years, neonatology has been blindly 100% focused on doing things only to minimize BPD and not focused on, hey, let's protect the brain, and we have to trade off a slight amount of lung injury for that. That's okay because avularization will continue up to age 8. But once you take out a neuron, it's not coming back. And the important focus is that premature infants can't autoregulate cerebral blood flow in the first few weeks of life. So it takes a lot of aggressive titration to protect that brain. So the whole point is always remember the brain protection has to outweigh the lung protection. So the key thing for good survival before 24 weeks is that we have to start before birth. And we know that antenatal glucocorticoids are critical for intact survival because they accelerate overall development and fetal lung maturity for babies under 24 weeks. Increases survival from 18 to 39% in one study for infants born at 22 weeks gestation. In another NRN study, where they combined the 22 and 23 weekers and increased survival from 36 to 54%. And it reduces severe morbidities, including RDS, severe IVH, NEC, and the incidence of neurodevelopmental impairment at 18 to 22 months, again, with significantly increased survival. I'll just ask people to, again, mute themselves. The way that why don't you go ahead and mute yourself there? Again, the primary thing for the lungs, what the antenatal glucocorticoids are doing is accelerating the differentiation of type 1 and type 2 alveolar cells. Thus, it thins the mesenchyme and alveolar septa, increases the invasion of capillaries into the air spaces, improving both oxygen transfer and gas exchange. Now, the rationale for using the jet for periviable infants is based on the developmental pathophysiology to reduce the risk of PIE and pneumothorax, but pneumothorax really isn't much of an issue anymore since surfactant at the canalicular stage of lung development, or how's it possible to survive without alveoli? About babies born in this area, basically 21 to 24 weeks, less than 24 weeks, Now, this straight line here for saccular is, humans don't work in straight lines. So based on what we found now over the past 30 plus years, there are some saccules developing as early as 21 weeks. So we have shown it is possible for gas exchange to occur down there. So during the canalicular stage of lung development, and you can see they last as long as 26 weeks in some babies, terminal bronchioles branch to respiratory bronchioles, branch to alveolar ducts, which terminate into alveolar sacs. They're thin wall and vascularized, typically beginning at 24 to 27 weeks. But importantly, the cranial segments of the lung mature faster than the caudal segments. So an adequate degree of lung maturation for survival can exist even at 21 to 22 weeks gestation if you minimize damage to the lung. So one, we need antenatal steroids to accelerate lung maturation. That's the first step. But two, we have to have a lung protective strategy to minimize valvular trauma. So Iowa, we're a first intention jet center for all infants under 27 weeks if they need invasive ventilation. And again, for infants born at 22 to 25, it's critically important to avoid both shear force injury leading to PIE, and what I'm going to talk a lot about is hyperinflation leading to cardiac compromise. And I'll show you a case of that. So the jet basically is a mode of ventilation utilizing rapid rates that exceed the rate of normal breathing. The jet runs 240 to 660. Normal breathing in our patients is usually 40s and 60s, maybe low 70s. The rates used during jet or any high frequency ventilation allow ventilation to occur using extremely small tidal volumes. These are below dead space. The classic dead space is 3 mLs per kilo. There are two animal models that do breathe with below dead space ventilation. One is the hummingbird, and the other would be a dog that is panting. And the whole point is we want to minimize the risk of barotrauma and valvular trauma, but combining them together, basically we're talking about shear force injury. This is an example of a wind in Iowa of 114 miles per hour that sheared the train right off the track. No one was hurt there. And then small tidal volumes used during the jet allow the safer use of optimal PEEP. So optimal PEEP is not exceedingly low or exceeding high. It's the optimal pressure for that degree of lung development and disease state. This allows us to minimize the risk of atelectasis and oxygen toxicity. And obviously the smaller tidal volumes, in this case below 1 ml per kilo, subject the lung to less shear force, decreasing valvular trauma. In the case of air leaks, primarily PIE, leads to less air flow through the leak, allowing improved healing. This is just an animal model showing within 20 minutes you can develop lethal shear force injury from barovalvular trauma. Now, gas exchange of conventional ventilation is pretty easy for us to understand because during conventional ventilation or spontaneous respiration, gas occurs from bulk transport or convective flow of oxygen and CO2 molecules between the central and conducting airways and the peripheral airways. There's basically 32,640 conducting airways we have to get through till we get to the alveolar sacs. And however, the volume of inhaled gas must exceed the volume of dead space, classically 3 mLs per kilo. So in high frequency, if we're ventilating below dead space, how can this occur? Now, there's 5 major methods that occur on high frequency, but just talking about the jet, the 2 major methods that are occurring are axial and radial augmented dispersion, which is Taylor dispersion. What does this mean? The gas is injected at very high velocity, so the friction plays a role on the inner surface of the airways. And so rather than have to fill up the entire 3 mLs per kilo, it basically shoots a jet of gas down the center. And since it's slowed down along the periphery, it allows the gas to exit if there's adequate expiratory time. The other thing that happens with the jet is you have a lot of augmented diffusion. If you increase the kinetic energy for the oxygen molecules, they're going to diffuse much more efficiently. So the consequences of this in terms of gas transport, on conventional alveolar ventilation is equal to tidal volume times rate. This is a linear relationship. So 10% better delivered tidal volume, 10% better delivered rate, 10% better ventilation. High frequency, however, is very tidal volume dependent. So depending on how your high frequency is being generated, it's usually tidal volume squared times frequency. So small changes in delivered tidal volume can make big differences in ventilation. So again, the benefit of high frequency is the ability to maintain effective ventilation with small tidal volumes below dead space, below 3 per kilo, minimizing volume trauma, shear force, and leading to ventilator-associated lung injury. So with ventilator-associated lung injury, you can have large tidal volumes. In my mind, if you have significant lung disease, any tidal volumes over 3 per kilo, I would consider relatively large, 3 to 4. Leading to regional overinflation, which leads to alteration of type 2 cells, abnormal surfactant dysfunction. It leads to alveolar capillary damage, increasing permeability, pulmonary edema, which also inactivates surfactant. You get atelectasis, compliance worsens, you get more lung injury. And if you happen to use suboptimal PEEP for the disease and development stage of the lung, so large tidal volumes, I'm not going to say low, but suboptimal, you end up with repetitive opening and closing of distal lung units, more shear forces, and more inflammation. So we want to kind of balance both of these out. For our population, it's really critical to prevent PIE for the less than 24-week gestation infant. PIE is gas outside the conducting and gas exchanging airways, which obstructs both pulmonary blood flow and ventilation and can develop within 48 hours of life. The earlier it develops, the higher the mortality, the earlier the chronological age, as I said, the higher mortality, the lower the birth weight and the lower gestational age. And in the pre-surfactant era, which is one of the simulations for the JET back in the late 80s, mortality for VLBW infants was greater than 60% whenever conventional peak pressure reached greater than 25 at any time during the first 2 weeks of life. So that's always concerning to me if someone says, well, they're using 5 per kilo volume targeted ventilation, and I ask, well, where is your pressure limit set at? And if it's 25 basically or higher, I'm thinking they're going to be causing a lot of shear force because that's a very stiff lung and they're forcing it open with a lot of shearing. They need to damage. This was a triplet. The other two had already passed away at the outside hospital from volume trauma, barotrauma, shear force injury, and was finally sent to us at a couple of days of life. Actually, they weren't even talking to the neonatologist, they were talking to the nephrologist because the baby had no urine output. Well, the reason the baby had no urine output, you can see this baby was massively hyperinflated with 4 quadrant PIE, and you can see the heart is completely compressed from the PIE, and therefore there was no preload. Without adequate preload, the LV fell off the Starling curve, and there was inadequate blood flow to the kidneys, which then shut down. We did fix the 4 quadrant PIE with optimizing the JET, but unfortunately the kidneys did come back. But when the brain is without adequate cerebral blood flow for a prolonged period of time, you end up with 4 quadrant cystic PVL, and the family withdrew support. Thinking about a global ventilator approach for these babies, I think it's pretty critical to follow CO2 levels very closely in the first 3 to 7 days of life to avoid fluctuations in cerebral blood flow. This is neuroprotective. I think we need to use proactive use of first intention low tidal volume strategies. Also lung protective, balancing everything out, whether you use JET or high frequency oscillatory ventilation, or low tidal volume targeted conventional devices with early rescue with high frequency being available when it seems like is taking a huge pressure cost to deliver that 4.5 to 5 per kilo. At 22 weeks, both Sweden and Japan and us, we all intubate electively with the 202, but 22 weeks, you don't want to struggle with that narrow place in the subglottic part of the trachea. And the number one thing is you've got to avoid this overdistension. This is neuroprotective, and it takes a lot of oversight and a lot of experience. And you want to focus on prevention of PIE due to the high mortality with PIE. And we'll talk more about, don't push them off the vent, extubate when ready for success, not failure. We're going to talk about you want to have a consistent ventilatory and respiratory strategy for all 22-week infants. There should not be random variation in management depending on the whim of the neonatologist. This happens many places where Monday's the JET, Tuesday's the oscillator, Wednesday's SIMV, PC, PS, Thursday's SIMV, pressure regulated volume control, pressure support. Friday is assist control, volume targeted ventilation with Draeger. All the outcomes are not adequate. And then oxygen saturation, we base our targets to minimize ROP and avoid false alarms. That's another hour-long talk on that alone. If we look at what Sweden, Japan, and USA, Iowa do similar for high outcomes at 22 weeks, we all push in anal steroids. We all don't let 22-weekers struggle, they intubate them. I'll let you guys meet yourself. We all intubate immediately with 2.0 tubes. The initial mode's slightly different. We obviously do high-frequency jet. In Sweden, they like to see if they can get by with volume targeted ventilation, but if their pressure is more than 22, they go right to Draeger high frequency. Japan tries a little bit of conventional first. Some places use the Draeger right away. Other places like to wait a few days. However, we all try to minimize volume trauma. We all try to minimize overdistension. And now that we're using low tidal volume ventilation, we try to keep CO2 goals closer to normal, more, 40s, 50s, and not tolerate anything over 60 to avoid increased cerebral blood flow leading to severe IVH. Now in Sweden, I talked about they will start at 4.5 to 5 per kilo volume targeted and with a slightly lower PEEP of 4. And if the PIP hits 22, they'll immediately go to high frequency if they're not ventilating. So in the US, we focused on use of jet ventilation to minimize volume trauma and to prevent and treat pulmonary air leaks, reduce BPD, and improve intact survival. The jet has been shown to increase healing of PIE, to reduce incidence of air leaks, to improve survival of babies with pneumothorax or PIE. In an RCT by Dr. Kessler, and reduce the incidence of BPD in half for infants with RDS treated with surfactant back in the 90s. A paper out of Brigham and Women's after they had adopted kind of the Iowa method of first intention jet. They compared it to their previous work with Draeger volume targeted ventilation 5 per kilo. And what they showed at less than or equal to 26 weeks gestation with RDS, they defined it as an OI greater than 5, jet versus volume targeted ventilation. The jet significantly reduced the incidence of grade 3 BPD by roughly 80%. And this was adjusted for gestational age, birth weight, and AA gradient. If you were at 27 weeks, it didn't really matter. Volume targeted ventilation and jet basically showed no difference. And at 26 weeks, if you had no lung disease, it also didn't matter. But for any baby, if you had a lung disease at 26 weeks or anybody under 26 weeks, it made a big difference. We showed in a very high-risk population, babies under 501 grams, so no argument about dating. The mean gestation, 23 weeks, mean birth weight, 440 grams. We had 61% survival with first intention jet. This was over 10 years from like 2012 to 2024. If you looked at 2024 bond survival at level C centers was only 27% of the same population. Grade 3 BPD was only 14% for us. Need for trach was only 6%, and these are under 500 gram babies. Grade 3 for IVH only 16. In ROP, needing any intervention laser Avastin was only 15. So what's so controversial with the jet is there's basically been 2 major randomized controlled trials, and they had different outcomes because they had very different management strategies, and these different management strategies led to the difference in outcomes. Dr. Wiswell's trial, published in 1996, the jet did not reduce the incidence of BPD, and it unfortunately had a very high incidence, increased incidence of cystic periventricular leukomalacia, and if you looked, a very high incidence of poor overall outcome, which was either cystic PVL or grade 4 IVH or death with the jet. The problem they had was they didn't know how to manage hypocarbia. The mean CO2 level was 17. Well, at a level of 17, basically you're shutting off all cerebral blood flow from cerebral ischemia. And they were stuck with a level of 17 because they limited the PEEP to either 4 or 5, and no one was allowed to increase it if the baby needed more mean airway pressure. The only way they could increase mean airway pressure to improve oxygenation, they had to increase the PIP. And once they started increasing the PIP to oxygenate, then the CO2 came down. If they tried to wean the PIP because the CO2 was low, they're back on 100% desatting, so they just had to tolerate the CO2 in that study. PEEP was not adjusted to limit tidal volume or to maintain or increase mean airway pressure, which unfortunately meant the MAP became dependent only on PIP. In contrast, Dr. Kessler's study, they managed to get a large portion of the institutions involved using adopting the PEEP when they needed to adapt it. So they found that the jet did reduce the incidence of BPD by half at 36 weeks PMA, without any difference in PVL or IVH. They allowed an optimal mean area pressure tidal volume strategy. They encouraged more PEEPs of 7, 8, or 9, but again, antenatal steroids were not being used as frequently, and surfactants were not as efficacious in the early 90s. So I don't want people to focus on that 7. It gets people in a lot of trouble, and I'll show an example of that. They had no hypocarbia. Mean CO2 level was 40. And most importantly, the PEEP was adjusted as needed when PIP was weaned to avoid excessive loss of mean area pressure and concomitant loss of oxygenation. Okay, so let's do a first case study. And this is just basically classic rescue. So this is rescue, using the jet to rescue an outborn patient about 400 miles from here with PIE. There were a set of twins, 24-week male twin developed severe PIE on day life 3 on volume guaranteed conventional ventilation 5 per kilo. His sister, and we know females are 2 weeks more developed, her lungs were completely, were very mature, and therefore her 5 per kilo only took pressures in the teens to get it versus his 5 per kilo took pressures went into the high 20s and higher. His PIE progressed with the left lung, as you can see here, hyperexpanded to 11 ribs with contralateral right-sided atelectasis and obviously severe respiratory failure. What's extremely upsetting is look how squeezed this heart is. So again, once we know, again, there's very poor cardiac output. This baby's falling off the Starling curve, minimal preload, minimal left ventricular output, which means minimal blood flow to the brain there. Was sent to us on day of life 10 for rescue with the jet. And after 48 hours on the jet, everything was fixed there. So the PI resolved after 48 hours. We had to use a rate of 240, which is an IE ratio of basically 1 to 12. Pressures, we get the pressures way down to 31/4, standard I time, and obviously no side breaths. So if this X-ray, I would consider this the perfect X-ray on the jet, 34% oxygen, a very happy heart, cap gas 730, CO2 59, +2, sats in the high 80s. So the key for rescuing one is first prevent it, but and so we're going to talk about to prevent things. You always use a long IE ratio so you can decrease air trapping and hyperinflation. I want to talk about the impact of air leaks, severe RDS, or most importantly, hyperinflation on pulmonary vascular resistance. So what this curve is showing is that you get into trouble at either extreme of the lung. So one extreme is where you're at completely collapsed with right down to your residual volume. And this is due to alveolar compression from external forces, pneumothorax or PIE, which is a lot easier to understand, or internal forces, atelectasis, surfactant deficiency. Either of these things will increase pulmonary vascular resistance, which then worsens oxygenation and VQ mismatch. And then the external compression decreases preload, worsening cardiac output and oxygen delivery. The other extreme is getting hyperinflated. So in this case, you're hyperinflating the entire lung, and you end up having this hyperinflation over distension. Here's an example of these hyperinflated alveoli, and you're now at total lung capacity. And at that point, your pulmonary pressures are also incredibly high, which is what we're showing here. So up high pulmonary vascular resistance, either direction. And if you have intra-alveolar overdistension from hyperinflation over inflation, it increases pulmonary vascular resistance and it compresses the pulmonary veins. This gives you pulmonary venous hypertension, which is very hard for people to diagnose this unless you're an adult looking at pulmonary capillary wedge pressures, but our patients, their total size is smaller than an adult heart. So you have to suspect this is going on based on using the x-rays. If you have intraalveolar overdistension, it worsens oxygenation and VQ mismatch, worsens ventilation because it limits passive elastic recoil. This is how you detect it. It worsens oxygen delivery also by decreasing cardiac output from inadequate preload from decreased venous return. Where we want to be is here, FRC, and actually, since they're not adults or children or term babies or 28 weekers, they're 22 weekers, we have to be a little bit slightly below FRC because most of the lung is conducting airways at this point. At 22 weeks, you only have about 500,000 alveolar sacs. At birth, you have 50 million alveoli. So we have to be able to have a little bit of haziness like here. And this is, like we said, on 34% oxygen. So this neuroprotective approach, like I said, it begins before birth. In the DR, how much oxygen do you use to resuscitate? So now what's good is the 9th NRP now allows people to use 30 to 100%, 30 to 90% oxygen. We've been using 50% oxygen in this population because we understand the huge AA gradient has to cross for a long time. And it's titrated per goals to minimize hypoxia and hyperoxia. If you look at some of the initial studies, mortality below 28 weeks when they resuscitated with room air was 22% versus 6% with 100% oxygen. I'm not saying to use 100%, but like you said, we use 50. Harvard, Brigham and Women's, Beth Israel use 60. Now there was a recent trial. You have to pull the supplement. If you pull the supplement in the torpedo trial, you can find that if you start with 60% versus 30, the 60% babies in the DR required less CPR, 2 versus 5%, less need for epi, 1 versus 2%. And importantly, more infantry SATs greater than 80% by 5 minutes, 58 versus 44%. Now, again, only 5% of their patients were 23 weeks gestation and 12% were only 24. And so long term, I think we looked at 15 months, they didn't see, so many other things can affect the long-term outcomes. But importantly, the short-term outcomes were dramatically different. And we know if you don't reach 80% by 5 minutes, this is associated with a greater risk of death or major neurodevelopmental disability by 2 years. So it's important to get here. And I think this is one of the things that we're very successful in, which is why I think we have low neurodevelopmental impairments, one of many things. Again, we talked about intubate right away with a 2.0 for 22. Depending on the size of the 23-weeker, usually 2.5 unless they're SGA, IUGR. Importantly, you want to intubate right away. Why? Because invasive in this population compared to non-invasive respiratory support in the delivery room reduces severe IVH and death at 22 to 23 weeks by 2-fold. So if you have a vigorous 24, 25, 26, yeah, let's see if they can avoid intubation. But when they tried that at Alabama for a long period of time, it did not. It just increased severe IVH and death. So this is not the population that you try to avoid that. You have to make sure you don't get right main stem. You can't use weight in kilos plus 6. You have to go more like 5.5 to 6. And this is an example of what happens when you put it in too deep. You don't get an X-ray until you have to give surfactant and show that you get all the surfactant to one lung. We bring to the NICU with general bagging, always focused on heart rate and SATs. We're talking about bagging by the ET tube. Now, we use a PEEP of 5. Why do we do this? Because we're trying to avoid getting hyperinflated. If you look at the SAIL trial, where they were very aggressive trying to get the lung open, they made the only point was focused, let's get that lung open right away based on data they've seen in rabbits. And fortunately, did the opposite in the tiny babies. There was a significant increase in early death. For all babies under 28 weeks, it was 7 versus 1.4%, which is highly significant. But almost all these deaths, 11 out of the 16 deaths were 23 and 24 weekers, no 22 weekers in that study. So it's important not to get these babies hyperinflated. And we obviously start within 10 minutes of life. We get on the jet, and then we give her surfactant, usually within 10 minutes after the initial chest radiograph to avoid this. And ideally, that always happens before the baby's, way before the baby's even an hour old. 2.0 tubes, there was a concern that could you ventilate or oxygenate with the jet? It's not an issue. We showed in this paper that we could have 2.0 tubes in patients as small as 240 grams who have survived. We certainly put them in even smaller patients, unfortunately, did not survive. And it's rare to get a 2.5. You can, but it's rare to, we don't like to use them in babies much smaller than 450. The 2.0 ET tube does require higher jet PEEP, 27 versus 22, to deliver the same tidal volume. This is expected based on, we know resistance to flow goes up the radius of the 4th power. So it's not unexpected. This doesn't mean the baby's worse. It's just what you need to do to overcome the resistance. And about half the 2.0 tubes do get upsized because those babies aren't yet ready for successful extubation. Importantly, there was no trouble ventilating oxygen with a 2.0 tube. In that paper, we had 77% survival of all patients who were intubated with a 2.0 tube. So The old days, people say, oh, if you need a 2.0 tube, then you're not viable. No, it just means you're just small. Back to the jet. The jet always works, as you can see. You always need a second ventilator in tandem to generate PEEP inside breaths. Again, the jet uses a pinch valve. It's a flow interrupter to generate a stream of high-frequency pulses of fresh gases to the tidal volume. This gas is injected at very high velocity through the high-pressure green tubing, it producing the flow streaming, as we said, Taylor dispersion, sending gas via laminar and transitional flow down the core of the bronchial tree, thus minimizing the effect of dead space, allowing ventilation with tidal volumes clearly below 3 per kilo, like 0.4 to 0.5. You need a conventional ventilator run in tandem to generate the PEEP inside breaths. But it's importantly, it's not an oscillator. It's not the it's not the Sensormedics oscillator. There is not a large negative pressure wave. So the exhalation is passive from elastic recoil. Now, this has a lot of benefits if you give adequate time for the passive elastic recoil to occur and don't overshoot the PEEP. If you're using, one of the studies of the oscillator published by Sherry Courtney in New England Journal in 2002, that negative expiratory wave, which is good with babies with a little bit more mature lungs, in the younger babies, it can actually start to cause collapse of the terminal bronchioles. And so if you looked at, and then therefore air trapping, and the incidence of PIE in that New England Journal RCT was 20%, quite high, versus 13% on conventional. So in the tiniest babies, the oscillator may not really be the best choice. And again, using lower rates with a fixed I time will lengthen the IE ratio, allowing more time for exhalation and reducing the risk of air trapping. So initial settings. Knowing that exhalation on the jet is passive from elastic recoil, the big breakthrough we had over the past 30 years was listening to everyone on the front lines, thinking about the physiology, and realizing the troubles that we were having a long time ago at 420 when we used it in smaller babies, and then even at 360. But at 300, everything's working perfectly. So the jet rate is based on gestational age, taken based on lung development. And the more you're deeper into the canalicular stage, the more time you need for this exhalation. So less than 24 weeks, our standard is 300, IE ratio of 1 to 9. We've used this successfully with obviously the 21 weekers too. 24 to 26 weeks, 360, which is 1 to 7. And the old school babies, 420 is fine, like the Dr. Kessler study. Obviously, if you do get PIE or pneumo, drop to a lower rate to avoid the air trapping. Again, at slower rates, more time is spent in expiration using the fixed I time of 20 milliseconds, which decreases air trapping from passive elastic recoil. So we always use 0.02, 20 milliseconds to reduce volume trauma. Again, we don't want air trapping. We don't want hyperinflation, overdistension, and of course, no hypocarbia. At 240, the lowest rate the machine will go, it's 1 to 12. Sometimes we change the rate by 60 as the baby matures. If someone's under 300 having issues, we'll drop then by 20 for fine tuning, because lower rates can also decrease alveolar ventilation, avoid hypocarbia. And higher rates can be used to improve both ventilation and oxygenation as the lung develops and you get more into the saccular stage, so it can handle more total lung capacity based on post-menstrual age. We do that. This is an example of a baby started, 22 on the wrong rate. This was started at a rate of 420. You can see already horrible cystic PIE developing very quickly. Pressures. You don't need to use any side press. Initially, your recruitment is when you bag your surfactant in. And on the jet, one of the mistakes people make is they try to bag it in just 30 seconds on each side. And really, after that, then you still need to bag 3 to 5 minutes. The jet tidal volumes are not going to spread it. So I've seen places where, the patients don't do better because the surfactant has not absorbed and has not got through those 17 branch points. Initial peak pressure for first intention use, we use low 20s if it's a 2.5, mid 20s for a 2.0. Obviously, you want to see some chest wall shake, and then you adjust on CO2. We always know tidal volumes proportional to delta P. This is the thing I want people to focus on. The initial PEEP should be 5 in all these patients in this population. We're in the antenatal steroid and improved surfactant era. even if you don't give antenatal steroids, there are babies like that female that could be quite mature. And so it's important not to get hyperinflated in the DR, because right away you're going to impede cerebral blood flow and transition to neonatal circulation. Because if you're hyperinflated, you have your pulmonary veins aren't going to drain from pulmonary venous hypertension. So we want to avoid mechanical injury to the extremely immature lung from hyperinflation, lung protective, and we want to avoid impeding venous return neuroprotective strategy. The range, we certainly used it anywhere from 3 to 14 during the entire hospitalization. And we just PEEP as needed based on appropriate aeration and inflation, 8 to 9 ribs-ish to avoid hyperinflation and overdistension. And we always want to balance oxygen toxicity versus risk of mechanical injury. I'd rather be on 34% oxygen and 8 to 9 ribs and slightly hazy than temporarily be on 21%, 9 to 10 ribs, and then soon get hyperinflated. And we have to remember that PEEP is generated by the inline conventional ventilator, but we set it based on the measured value on the jet. I want to know what that lung is seeing. So we adjust the conventional to have the PEEP. Now, I'm going to show you a case where they started with an initial PEEP of 7 because they were trying to copy what was done in the 90s, which is not appropriate for 22-weekers. So this was a 22-week baby, less than 400 grams at another center. The initial PEEP was 7 centimeters. They did not get enough x-rays other than the first x-ray. And at 3 hours of life, they did wean to 6 centimeters because the baby's oxygenation had dramatically improved. So they thought, oh, let's wean a little bit more. And then had severe respiratory acidosis. And finally got an X-ray at 8 hours to try to figure out why they're so acidotic, as well as why they couldn't oxygenate. And this was the X-ray at 8 hours. Again, they didn't do much other than going down to 6 centimeters. And because they're so acidotic, they cranked the PIP up. And by 18 hours, the baby was dead from severe hypoxia and respiratory metabolic acidosis and hypercarbia because it got trapped into this hyperinflated state. So they kept going up on the PIE, which then caused higher pulmonary vascular resistance, and they added all types of drugs to try to reduce pulmonary vascular resistance, but this was not arterial, this was pulmonary venous hypertension. And this happens very quickly. This is a silent killer, and I encourage people, you have to get x-rays a lot more frequently than you think in the beginning. And the key is not to start, 7 looked good when they had the x-ray at 2 hours, but the baby was doing too well and waiting, and they should have backed up a lot more aggressively. It's much better to have a film hazy and white it out with a well-filled heart because that's easy to fix. Okay, let's talk here about sigh breaths. So sigh breaths, when you're on first intention, you don't need to start with any sighs. Once the baby's getting better and you're doing a lot of weaning, when you develop atelectasis, which I call focal or wandering atelectasis, then we use the sighs for velar recruitment, for patchy wandering, and you continue once started. The chest wall is not going to mature. The diaphragmatic, intracostal, supraclavicular muscles aren't going to be matured yet. And the baby's repositioned. We're still at the bottom of the gravity well on Earth here, not the International Space Station. So once you start it, you leave them on it. These are not adults where the problem is they got some atelectasis because they were temporarily paralyzed during intubation. No, these are babies that a lot of development has to occur. So you just leave it alone when started. You just need to make sure your PIP is just high enough to move the chest wall slightly, to exceed 4 per kilo there, roughly 3 to 4 per kilo. And the eye times have to be a little bit longer to get above the critical airway opening pressure, so we use these 0.4. And the other thing that we use them for is intermittent hypoxemic episodes. And these present with significant desaturations below 70, 80 when the spontaneous respiratory rate drops less than 15 to 20. So a rate of 4 is inadequate. You have to basically increase the rate up to 6, 10, 12, usually at least 10 or 12, sometimes 14. And you can see here, this is an example, when the baby's doing great and breathing a lot, the sats are good. Now the baby slows the breathing. They're not apneic, doesn't go apneic, not breathe for 20 seconds, but just breathing under 22 times a minute for 90 seconds drop this sat almost down to 60%, because these babies, as I said, have no residual volume. So they can't go like an adult who arrests can go 5 minutes of CPR while you look for an AED because the adult has a huge residual volume. These babies can't really go more than 3 to 5 seconds without starting to desat, which is why when people are on conventional ventilation, you're not on a rate of 4. I mean, you're usually on much higher rates, 25, 30, 35, 40, because of the desaturations until they've outgrown that. Obviously, if you have PIE or pneumothorax, you'll get the rate to 0. We have balanced ventilator goals, so we follow neuroprotection outweighing lung protection. So we don't want to be hypocarbic, but you also don't want to be hypercarbic in the first week of life. Permissive hypercarbia, which I'll say is greater than 60, is a little bit different once you're a week old and you're able to have autoregulation of cerebral blood flow. So we'll target 40s, 50s the first 3 days, 40s to slightly higher, 50s the next 4 days. This sometimes require gas if we have an art line every 3 hours, but even the first 3 days, we will cap stick at least 12 times to make sure we're not having that CO2 too high or too low. The other thing that a lot of people forget is you've got to detect hyperinflation before it's end stage. So we will get chest radiographs at least 3 times a day for the first 3 to 4 hours. And most importantly, we'll also get it 2 to 4 hours after a dose of surfactant, which usually 4 hours after the dose, which that team did not, which is why by the time they picked up a problem, it was too late. And then saturation, we have different alarm limits and target sats to avoid alarm fatigue, as well as to reduce our ROP. These babies do require potentially repeat surfactant for babies under 24 weeks. About 20% of infants under 1,000 grams do develop post-surfactant slump. So this is when they worsen and the x-ray looks just like RDS again. This usually occurs, you start to worsen after day 3 and dramatically worsen after day 7 to 10. It's a lack of, this post-surfactant slump is a lack of endogenous functional surfactant or inactivation. And about 63 to 70% of infants will get better. Now, at the same time, you could have a large hemodynamic significant PDA flooding the lungs, so you got to make sure that's not an issue. The other thing that also happens at this time to lead to inactivation is unsuspected sepsis or pneumonia. A lot of these babies that people try to do a rule out on can get quite sick between day 7 and day 10. We don't, it's a whole nother story about we don't do rule outs in this population. They get 7 to 10 days. If there is a large duct shunting, you're going to have to start working on getting that duct to close. Why thinking about, do I need to, at some point, I need to actually recover the lungs too. And the duct doesn't have to completely close, you just have to reduce the shunt. Extubation, it's very different at less than 24 than it is at greater than 26. We want to minimize risk of atelectic trauma and apnea leading to failure. If you fail extubation, and the data shows even for more mature babies, 24 to 26 weeks, if you fail in the first 2 weeks of life, and these are babies basically mean 26 weeks, failure is associated with increased death, 28% versus 6%. So 5-fold increase in death if you're going to fail, as well as, of course, worse BPD, worse sepsis, and worse severe IVH, and controlled for everything. Again, if you fail in the first 12 days, again, it's the babies at high risk or less than 26 weeks. Even 72 hours after back on the vent, everything still is much worse. So you've fallen way behind. And then the APEX cohort, which is it's 5 centers that are really working hard at minimizing BPD. They looked at early failure in the first week of life, and again, showed much greater risk of death. And their deaths were from grade 4 IVH, pulmonary hemorrhage, respiratory failure, NEC. And again, these were babies less than 26 weeks. They had no 22-weekers in APEX, and they have 100% failure rate at 23. So I think it's important to minimize multiple failure attempts and give these babies time that when you do extubate them, you have success. We extubate everyone at this gestation in non-invasive ventilation. I think part of the problem is we need to use a more development appropriate marker for pulmonary outcomes. So here's normal lung, here's old BPD, back in the days when you can use oxygen 36 weeks as a marker. But new BPD is different, which is disruption of lung development with the risk of alveolar septation and vascular development, leading to the alveolar simplification. So when you're dealing with this population, I think it's much more valid to use, for infants born at the canalicular stage, Eric Jensen's work, 21st century concept, which is the need for invasive mechanical ventilation at 36 weeks instead of the old 20th century concept, supplemental oxygen, which is perfectly great definition for 27 to 28 weekers, but not for 22 weekers. We want to make sure they're alive, so we don't have grade 3A, and we want to make sure they don't have grade 3, which is stuck on a ventilator. So our goals, again, avoid lethal BPD, which is death from respiratory failure, and 2, reduce grade 3 BPD, which is still stuck on the ventilator 36 weeks, because grade 3 is what's associated with need for trach and moderate severe NDI. Why is this so important is that if you look at the proportion of deaths due to a respiratory cause for inborn 22 weeks infants admitted at Iowa, our respiratory causes were only responsible for 8% of the deaths of infants born at 22 weeks.
You're muted.
Dr. Klein, we couldn't hear you. You are muted.
You're muted. You're muted. No, still can't hear you.
Try this.
Now we can hear you now.
Oh, you can hear me now? Feel like I'm in a Verizon
Yes.
commercial. All right, sorry. I probably started waving my hands and started hitting, buttons all over the place. Okay, so you can still hear me. All right. So if we look at this Sunny Jewel paper, what was shocking to me was even at 24 weeks, the cause of death was respiratory in origin. 60% of the cause of death at 24 weeks was respiratory. And for us, our 22-weekers using first intention jet, only 8% of the deaths were respiratory. So, and then 50% of the deaths for them at 25 weeks. So I feel comparing to a cohort that's roughly the same period of time, there was 2013 to 2016, ours 08 to 2017, that it shows, I think, that you can get your respiratory causes of death down to less than 10% for a population that a lot of people consider pre-viable. Okay, so respiratory outcomes that we had published, if you looked at in this paper from 2020, 70% survival in that paper at 22, 82% at 23. Median duration of ventilation for 22 and 23 weekers, 63 days. Seems like a long time, but actually it's only 31 weeks PMA. And the interquartile range is 29 to 33. So a quarter of these babies are off before 29 weeks PMA. Importantly, how many had grade 3 BPD, still needing to be on a ventilator at 36 weeks PMA? 6% from 06 to 2015. I redid it from 2016 to 2023 because we started getting a lot more moms sent to us who had ruptured before 20 weeks, and so that went up to 9%. But importantly, from 06 to 2023, only 3 out of 212 22 and 23 weekers were trach, which is 1.4%. And 31 weeks is not that bad because if you look at the Apex cohort, and their median gestational age was a week older, it was 24 versus 23. They had the same postmenstrual age of extubation of basically 31 weeks. This is a 22-week twin male. That's why he's bigger. First intention jet. His brother did die, unfortunately, of NEC. This is him at 9,000 feet. And the twins I showed you at 22 and 7th, they were on oxygen for almost up to 2 years. Okay, non-pulmonary outcomes very briefly, again, over a long period of time. At 22 weeks, severe IVH, 21%. Cystic PVL5, VP shunt, only 3%. Actually, our VP shunt for all 22 and 23 weekers, we only done 4 out of 211 babies, 2%. Neck, 11. 23 drops to 8. ROP treatment's only 11%. In Japan, 22 weekers getting treated is close to over 40%. It's important to realize, males do not develop as well as females. So there's very few male 22-week twins living. His brother died within a day or two from grade 4 IVH. His brother also died of NEC. Feeding 22 weekers is a big challenge. So in summary, at 21 to 23 weeks, lungs at the canalicular stage are at high risk of mechanical injury from air trapping, leading to PIE and hyperinflation. Keys to intact survival, antenatal steroids, minimizing VIA trauma with low tidal volume ventilation, avoiding hyperinflation with appropriate PEEP, and minimizing extubation failure during the first month. First intention, even with the 2.0 tubes, effective at managing infants before 24 weeks, including 21 weeks. And it's certainly possible to ventilate infants born less than 24 weeks with high survival, 66 at 22, 78 at 23, with low rates of grade 3 BPD and trach with intact neurodevelopmental outcomes. Very long term, this was a baby I took care of a long time ago, 24-week female. She won national championship, well, Division III champion, graduated college, and got married when she was 29 years and 10 months. So there's a long-term outcome. 29 years and 6 months for prematurity. Limits the viability. It's interesting. I'm not sure anymore. I was more sure 35, 40 years ago. And I was showing this. This is the 240 gram. Here's first intention jet. And here's a 21 weeker here with first intention jet. And this is him with his mom here. This would be our smallest, I'm sorry, misspoke, most premature baby, 21 and 0, first intention jet. Of course, on nasal cannula oxygen, I expect him to be on it potentially up to age 2, but we'll see. This is him. To me, he looks like an adult sitting in his chair. So I don't think going home with nasal cannula oxygen is pretty much expected for this population. There's a big difference between a 26 to 27 weeker and 22, well, in this case, 21 and 0. Okay, up 7.13 months adjusted age. Oh, and 18 months, 13 months adjusted age. I have my developmental stuff. And currently we have 6 to 7 21 weekers discharged home. And there was a paper on the 6 that have already been discharged home published recently. So with high frequency, this is the inventor of the oscillator. And he once said the RCT is ideal for evaluating things like drugs. As randomization eliminates further medical input, it's far less effective in testing technologies where the whim of the physician controls the way in which the technology is applied. This tactical variability has plagued and will continue to plague the evaluation of new ventilatory strategies. It was now clear that we're testing the driver, not the machine, and that education was the only solution. So thank you. And I'm going to stop sharing.
Thank you, Dr. Klein. That was an absolutely fantastic presentation. If anyone has questions, if you could please put them in the chat, it would be easier for me to, then I can read those and we can review those. But before we take questions, Dr. Ali, the chair of our division, I didn't know if you wanted to add anything from your perspective.
No, actually, it's excellent work and congratulations, Dr. Klein. It's really, really very impressive. And I definitely like your strategy. We're trying to really improve survival. In this 21, 22 week, the problem is not the PBD, because even with our experience with the bubble CPAP, we have a very low BPD rate of 6.9%. Almost all of them, or the majority of them, are coming from that population anyways. We just don't like to use the Johnson criteria because it basically favor the use of nasal cannula, because if the baby on nasal cannula have a less degree of BPD than if you don't CPAP, while we like to use CPAP.
I'm sorry to interrupt, but
and the most recent meta-analysis in pediatrics just came last month and didn't show any superiority for prediction of neurodevelopmental outcome. My question to you, of course, we will not have, these babies don't have alveoli, or maybe they don't even have sacs. They have just canaliculi. And we do not, so I don't know what's the role for surfactant. So I have to give a dose of surfactant because I'm not going to experiment on a baby. So at least I'm going to give him a dose of surfactant. But in your slides, you give more than one dose. So did you notice any improvement, or what's your experience with repeated dose of surfactant for a baby who has no alveoli?
So, I mean, they do have alveolar sacs. Otherwise, there cannot be any gas exchange. So we know they probably, have about 500,000 or so alveolar sacs, and certainly we've seen babies that respond quite well, and we usually give them a minimum of 2 doses. And I honestly think people should be giving them 3 doses, automatically at 0, 12, and 24. But a lot of feelings are, hey, if you're doing well after the first 2 doses, but I've seen times where people have decided not to give any doses, and they're like, and then the baby falls apart and develops severe PIE within 24 hours, blows pneumothoraces, which we haven't seen for decades because people should be giving surfactant. right away. So I feel there's clearly a role because they are going to have to make their own exogenous surfactant, and a high percentage of these babies are infected. The rate of chorioamnionitis at 22 and 23 weeks is 73%, as shown in the NRN study. And certainly in the studies where they're looking at actually even positive blood cultures, the rate of positive blood culture, which is actually hard to get in babies this small, for babies under 24 weeks, like 22 and 23 weeks, is 3 times higher than it would be at 26 and 27. So we know infection can also inactivate it. So I think my bias is that it is important to at least give 2 doses.
Okay. Just before the crowd leaves, I want to make sure that there's a second lecture by Dr. Klein to follow up. So if you're going to go over, if Allison would like to go over a couple of more questions, but just to make sure that the team knows that we'll have a second lecture too.
Yeah, March 18th, and hopefully we can figure out maybe a way for maybe some more time, and then we can actually try to do questions in real time.
Excellent. Thank you. So okay, you do use a second dose of surfactant, sometimes third. And then we have a question. How long do you usually leave the side breaths once you initiate for atelectasis?
So once a side breath is initiated, it should be left until extubation, because what you're waiting for is for the baby to develop enough chest wall strength, chest wall rigidity. They have to develop muscular strength. Otherwise, it's just going to reoccur because the nurses do a fantastic job with cares and repositioning the babies. So the point is to leave them on, because every time they reposition, I can't tell you how many emails I have from people with the same exact story. We put side breaths on, the atelectasis goes away, we stop them, it comes back. We put them on, it goes away, stop them, comes back. And what you don't want to do is hyperinflate the lung to avoid focal atelectasis in the right upper lobe. Then you get into big trouble. So what you want to do is just leave the side breaths on. And the side breaths are not designed, they're not there for ventilation. They're there to get above the critical airway opening pressure of some areas of atelectasis that have collapsed because of dependent atelectasis. And so once you start them, you leave them on. We do not, side breaths are not used for complete diffuse whiteout, and that you're going to increase the mean area pressure, for example, by going up 1 and 1 on the PIP and PEEP, or potentially that baby might actually need more rate to increase the mean area pressure.
Okay, excellent. Next question I have, what is the average age when you are extubating?
So, for the entire population, it's 31 weeks post-menstrual age. But over a quarter, so in terms of age, we usually talk about it. So most of the babies, the standard 22-weeker, at about a month of age, we probably have a very intense discussion about, do we think this baby could be extubated successfully? So we're going to address, is the PDA an issue? Yes or no? Are feeds an issue? Yes or no? Does the baby still have a central line in? And so we'd rather try to have that baby on full feeds with the central line out, and then consider extubating them. So we don't, so we don't rush any of these babies off. So on average, half by 31 weeks PMA, which then, like I said, matches other places don't even have 22 weekers, which is about 60, 70 days of life. But more than a quarter are extubated before 49 days of life.
Excellent.
And it's all individualized, obviously, but we'll have a conversation. If this baby's flying through, and we might go, gee, the PDA is a non-issue, the baby's on full feeds, the central line has been out, and the baby is not having death spells that require increasing of the side breaths, let's then think about extubating. So we don't leave everyone on, only if they need, we basically, and a lot of them, some of these babies are so tiny, since we use non-invasive NAVA, we'd like to have the 21 and 22 weekers, above 850 grams, because they're so immature, their entire system is so immature, skin, muscle strength. It's very different. If we have a 500 gram 26 weeker who might be extubated day 1 of life, and then in which case we're not going to use NAVA, but we'll use nasal intermittent positive pressure ventilation. So there's someone with no lung disease and is an IUGR 26 weeker, that will be a whole different story.
I have lots of questions regarding postnatal steroids. Do you use hydrocortisone early? And then also DART. What are your thoughts on that?
Okay, so I have an hour-long talk about steroids, but just to make it short, we will use hydrocortisone. We don't do the Premaloc study. We can talk about that for a long time. We will use hydrocortisone. We do a very short 4-day course to use it for isolated hypotension unrelated to septic shock. So that's kind of stress dose with a quick wean. We will do the 10-day, and there's an NRN 10-day hydrocortisone course that we talk about, that we often do at 14 days of life, because that has been shown to improve the rate of extubation success, which I think is important. It wasn't shown to make other differences, but there was a strong trend toward less mortality. So we will do that. But now when we're talking about babies about 30 days. We then will talk about, that's when we will consider the DART, depending on the level of oxygen we're in, or it's someone that we may want to reduce airway issues, but we don't have much subglottic edema. But if that was a concern, that we know from one of the other NRN studies that you don't want to wait until after 50 days before you give your first course of dexamethasone. So we usually talk about it at day 30. If someone's on more than 70% oxygen, we might consider doing it as early as even 14 to 21 days. If that hydrocortisone didn't work, maybe we're doing it 21 days. So we certainly have done DART early. We know from Eric Jensen's work and many others, if you're doing DART, it often takes 2 to 3 courses to really see full impact. So we're always prepared after the DART's done for the baby to have a backslide and get restarted on double DART or triple DART over the period of time. And we know from all that great work that if someone is at a risk of more than 60 to 70% of having severe BPD, that actually the steroids, the dex will actually be neuroprotective. If you're giving it to babies that are at minimal risk, it's obviously harmful in terms of CP.
Okay, and then could you provide us some strategies for hyperinflation reduction on the jet, particularly if the hyperinflation develops on a different mode of ventilation?
So I think let's say, I think the main thing is you're going to have to tolerate high FiO2 to get it collapsed down. And so we would probably, like we rescued that baby I showed you, that we used a rate of 240, and to allow it to collapse down and reset, you have to tolerate much what I call cardiac sats sometimes to get it collapsed down. So what we'll do if we're rescuing a disastrous situation, instead of saying the sats would be, targeting, 80s and high 80s, low 90s, we would switch to say, okay, as long as the sat is above 75, we're going to turn the sat limit like 75 to 90 or 65 to 85. You have to tolerate 100% oxygen temporarily to get that collapse down. Once it's collapsed down, then we would give surfactant to and then we give the pressure. We can then hopefully reopen the alveolar sacs and not it travel then into the area that's being kept open, which is the PIE. So the whole thing is, once you collapse everything down and give surfactant, you're going to reopen the sacs. You're not going to reopen the area with the PIE. But it's very hard. So sometimes you have to kind of go into a cyanotic congenital heart disease mode. I talk a lot about that in the workshop. It's a very difficult thing. We're trying to recover from this hyperinflated state, because what you're seeing is external to the lung. So you need that long 1 to 12 IE ratio. You need not to have any sigh breaths. You need to tolerate really high FiO2. Sometimes you might tolerate it for 12 hours or 18 or 24. And then things will collapse, and then we'll get better once you start giving the surfactant. The latest, I think someone said about the latest we've given surfactant. I think in our paper, probably as late as like 25 or 30 days, a repeat dose.
Okay, here's something also that I'm really interested in, sedation, drips. Do you use much of that for these tiny babies or no?
No, they don't need any sedation.
Excellent to hear that. Thank you.
The worst, I mean, sedation is a really good way to cause neuronal apoptosis. And there's this, we did RCTs a long time ago showing that outcomes were much worse sedating this population. And that usually the reason, they're desatting is, sometimes they need suctioning, sometimes they need to be fed or changed or repositioned. Now, surgical pain is different, but routine sedation is not needed. And in fact, many times they do. And if the baby's having most of the desaturation spells that they have as they get better, let's say second, third, fourth week of life, let's say 24 weekers now, 27, 20 weeks PMA, because their lungs have gotten so much better, the jet support has been weaned dramatically by a large amount. And then when the baby is breathing slowly, if the baby is breathing slowly, more in the teens to low 20s, there's not enough oxygen in the residual volume, and then they desat. And so what needs to happen is you need to give them enough breathing support with the side breath, because it has to get down to the alveolar sac. So you have to exceed 3 per kilo, which the jet at that setting is not high. It's not roaring along and circulating a lot of molecules of oxygen in there. So just like I took a sigh, you need to give them a sigh, and it works quite well. And a lot of times it's similar to if you use any type of non-invasive ventilation. Like I said, you don't have your non-invasive ventilators set at rates of, 3 or 4 or 5. You probably have them set at rates of 15, 20, 25, 30, 35, 40 if the baby's having normal lungs but having apnea spells. Obviously, you optimize the caffeine too.
Thank you so much. Guys, we have to finish up pretty quick here, but there is one question about the adapter modified for the 2.0 ET tube. Do you want to add anything to that?
Well, so, they're working with the company is, so let's go back way in history. When the company first started, there wasn't even a 3.0 adapter. So eventually, so we used to put the 3.5s into the 3.0 tubes. And eventually they made a 3.0 adapter, and eventually they made a 2.5 adapter. They're working with the FDA to see if they sent all our publications to show that for these tinier babies and more premature babies, that you have to have a 2.0 tube, otherwise they're not going to be living if you try to force a 2.5 in. And so basically we just take the 2.5 adapter and weasel it in. We dilate, we take the 2.5, a regular 2.5 ET tube adapter. In fact, we take the 2.0 adapter and push the 2.0 connection and push it to the hub, get the thing dilated circumferentially, and then take the 2.5 and weasel it in. You don't want to try to dilate it up with a hemostat because you'll just split the 2.0 tube. So we don't find it much of an issue at all. And a 5 French, will suction just fine because that is the 1.5 millimeters in diameter, and the 2.0 tube is 2 millimeters in diameter.
Thank you. And there's a last question about, do you have an antibiotic policy for babies that are on prolonged ventilation?
No. I mean, because obviously we have we're not going to have someone on 6 weeks, 8 weeks, 12 weeks of antibiotics. The concern, the major issue is people trying to do a rule out at 21 and 22 and 23 weeks, which they're incredibly high-risk population. If you look at histologically proven chorioamnionitis, it's over 70% in this population. And the hit of a positive blood culture, ranges anywhere from 10 to 20% of the time you get a positive blood culture when you have a clinically ill baby. And the adults already know this. The adults, don't stop antibiotics because they only get a positive blood culture 30 to 50% of the time with 40 mLs of blood. So I think they look at the big picture and decide, oh, okay, this adult clearly has signs of sepsis. We're going to continue antibiotics and not stop them because the 40 ml blood culture came back negative. Neonatology, I think we're asking us to hold standards that adult ICUs don't, especially in this high-risk population. I think it's very different if you're talking 26 weeks, intact membranes, mom, the delivery because of preeclampsia, sure, do a rule out, but at 22 weeks, 23 weeks, the risk is way too high. And a lot of the babies, centers kind of fall apart when they do the rule out, and they fall apart, at the end of the first week. But I will say what we do prophylactically, we do give fluconazole for a few weeks until their skin is keratinized. And that's from Danny Benjamin's RCT shows that will work quite effectively. And then
Okay,
also,
well,
there's a whole bunch. I could talk for like 8 hours on all the things that have to be done at 22 weeks. That's completely different talks.
all right. Well, thank you so much. This was absolutely fantastic. And we will see you on March 18th for part 2. Thank you, Dr. Klein.
All right, thank you.